So
Can you do the screen? Can you do the screen share, Mohammed?
yes. So Rabbi Shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Oh God, please open my brain and my capacity to communicate with you guys today. I have been given a very huge task to do a presentation on pediatric emergencies in 20 minutes time. I'll try to be as efficient as possible, and I'll give you some chances to ask any questions because I might need to leave as soon as I finish my presentation. I have some prior commitments. So just to involve everyone, could you please unmute your mics and make a guess what is the fastest sports in the world? Let's take a quick start. Anyone?
NASCAR.
Chess.
Attempted chess, did you say?
Yes.
Oh, that is the slowest game in the world. Chess. Anyway, let's not waste too much time. So badminton is the fastest sports in the world, and I play badminton. That's why I just educate everyone. So fastest speed recorded is 473 kilometers per hour is the shuttlecock speed. My today's presentation, I was thinking, how should I make it easier for you guys? And my understanding is that maybe Dr. Saifullah would like me to give some tips how you guys could identify while you're in the general practice, how you could identify the pediatric emergencies. And I wanted to give you some tips based on a systemic kind of approach. I would not go into the details of these emergencies, but I think this would be a quick tip guide. And I understand you guys have a very limited time while you're seeing, you have got a very high patient turnover and you usually have 5 to 15 minutes to spend with every patient. So if we have these tips in the mind, and hopefully it will make your life easy to recognize the emergencies and what could be the appropriate things you could do in the limited available time. So let's start with the most dreaded thing for everyone in the general practice and even in the pediatric world is the neonatal emergencies. So what is the normal temperature for a neonate? Anyone? You know, people ring us all the time. They say, this child is not febrile, his temperature is stable. I just want to know, what is the normal temperature? Anyone?
$36.5.
So the normal temperature is a range between 36 to 37.5. So 36.5 to 37.5 to be very accurate. But in neonates, I'll give them a grace of 36 up to 36 to 37.5. So please, whenever we are communicating and talking about neonates, we need to record their temperature and mention that, because whenever we say that this neonate has got a normal temperature, it doesn't mean anything to me really if we talk in the pediatric world. So if they have got a low temperature or if they've got a high temperature outside this limit of temperature, they could be presenting with sepsis. So they don't only present with the high temperature with sepsis, they can present with low temperature as well. So this is a pediatric emergency, and I would suggest that you guys refer them on urgent basis if the temperature is outside this bracket. Jaundice. If a child is coming to you in the early neonatal age with jaundice, what's your thinking process? Anyone? Let's get involved and get over this presentation. I want to make it more useful and interactive for you guys.
It's supposed to be a interactive and proactive presentation. So
physiological and pathological causes.
Yeah, I mean, everyone will think about physiological and pathological, but the only one thing I want you guys to take away today is sepsis. So the children presenting with sepsis, they need to have an exclusion for sepsis. So they need to be referred for an assessment and management. They need to be reviewed by a pediatric team because jaundice is one of the type of presentation for sepsis. Any kind of hemolysis in the body can present with jaundice, and hemolysis is one of the reasons for sepsis, as you guys would understand. So let's talk about tachypnea in neonates. So again, neonates would present with 100 different variety of symptoms. And the only one reason I want you guys to think of is sepsis. Let's move on. A neonate is presenting to you who has missed more than one feed. Please remember, this is an emergency. So any neonate who has missed more than one feed. So normally neonates will feed every 3 to 4 hours. So they have not taken their feed for last 6 hours or 8 hours. That is an emergency. They are dehydrated and they possibly have something bad going on. I would like them to be evaluated by pediatric team and excluded for sepsis or something else emergent. So this is an emergency if they've missed more than one feed, because feeding is a very important marker in the neonatal world. Tachycardia. So the neonatal heart rate can go as high as up to 180 beats per minute. That is higher limit of normal heart rate for them. But if I would suggest for you guys, if their heart rate is more than 160, please make them reviewed, or maybe check their heart rate again in 5 minutes time and see if it's settled once they've stopped crying. If their heart rate is below 160, I'll be happy, but otherwise they need to be reviewed. Pale stools, that's very, very important. What do you guys think about it? What would be your thinking process? That's only one thing I want you guys to think of when they're presenting with pale stools. And remember, everything I'm presenting today, I'm presenting with the lens of pediatric medicine, okay? So don't confuse with the adult medicine. So pale stools in a neonate, what are you thinking of?
Some obstructive jaundice.
Yeah, so absolutely right. So I'll be thinking of biliary atresia. So this child is not able to pass on its bilirubin to give a normal color to the stool. So the normal color of the stool, the yellowness or greenness, it's coming from the bilirubin part which goes into the stool. So they have got biliary atresia. This is an emergency. They need to be seen by the pediatric gastroenterology team for an urgent surgical procedure or a plan for surgery. So remember, we see a lot of children referred to us with the blood in the stool, but this is unlikely to be a pediatric emergency, unless these are premature neonates and they are presenting with the blood in the stool. That is the only reason of thinking of pediatric emergency. Otherwise, unlikely to be, and they could be because of, allergic reasons, cause milk protein intolerance, and various other reasons can present with the blood in the stool, but it's not an emergency otherwise. So neonatology take-home messages, only two take-home messages for you guys. Always consider sepsis, and an estimate of their birth weight with their current weight is an absolute measure how well these neonates are thriving. So you need to weigh them. You need to expose them and weigh them properly. If they are putting on weight, they are well neonates. If they're not putting on weight, that is a worry for me. This neonate is not very well if he's not putting on weight. So these are the two absolute take-home messages for you guys, not a long list. So if they're taking their feed, they are putting on weight, they likely are healthy neonates. All right, let's talk about neurological emergencies. Any child presenting with a seizure or altered GCS is a pediatric emergency. You need to consider the sepsis with meningitis or encephalitis, a space-occupying lesion, or a CVA. I think the things you can do in your rooms is checking their blood sugar. That is the only thing you can do, and that is the one thing we really need to know when they have a seizure. What's their blood sugar level? Or if they've got an altered GCS, what's their blood sugar level? So I would suggest you guys to take home that anyone presenting like this, you need to check their blood sugar. Now, I'll just mention the dose of midazolam there. So if there's a seizure which is, prolonging more than, 5 minutes, you should be getting ready for midazolam. And it's easy to remember the dose of midazolam. It's 0.1 milligram per kilogram. If you want to give it IM, or if you want to give it buccal or through the nose, you can give it 0.3 milligrams. So the maximum dose is 10 milligrams. It's very easy to remember. So it's only one dose, only one medicine I want you guys to remember for neurological emergencies. If you are living far flung, I don't know about the geographic of all of you guys. I'm meeting you guys for the very first time. But if you guys are living at 1 hour distance or 2 hours distance from the referring hospital, I would suggest giving them first dose of antibiotic. You can give it IM ceftriaxone. It's very easy to remember. Weakness, any child presenting with a weakness anywhere. So you need to consider a tumor or CVA. Again, remember to check their blood sugar. I'm gonna continue reminding you guys about blood sugar. That's a very, very important component of our assessment in pediatric world. One thing which still scares me after so many years of pediatric training, what about you guys? Is there one single presentation which scares you guys in pediatric world? Anyone?
Arrest.
Arrest. I mean, this is this child has got an arrest and you can manage it accordingly. But one thing which still scares me is isolated vomiting. You guys might be laughing at me, but isolated vomiting is really scary thing, because this could be a presentation for a million of things. It could be a presentation for meningitis. It could be a presentation for a UTI. It could be a presentation for a respiratory tract infection. It could be as simple as, RT, but it could be as complicated as raised intracranial pressure. And the message I want you guys to take home tonight, please don't label a child with gastroenteritis if he or she is presenting with isolated vomiting. This absolutely needs to be evaluated. All right, neurology take-home messages. Blood sugar level, please check their blood sugar, and isolated vomiting. It needs exclusive assessment and evaluation done, please. Let's move on to respiratory emergencies. I think it's pretty simple. You guys this is the most common presentation for the pediatrics, especially when the weather is changing and now we're getting into the cold weather. Shortness of breath. So it could be a presentation for asthma, bronchiolitis, croup, foreign body, lower respiratory tract infection. Anyone can give me a differentiation? How would I differentiate between bronchiolitis and a reactive airway? If they both can be presenting, with the crackles or, wheezing, how I'm gonna differentiate, or how I'm gonna proceed? Any thinking process from you guys?
Age would be one. Like bronchiolitis is usually from
Age.
infants 1 to 3.
Absolutely. So the cutoff nowadays, previously when I was a trainee, we used to have a cutoff for 2 years, but now the cutoff is 12 months. So under the age of 12 months, unlikely to be reactive airway. But unless they've got a very strong family history of asthma and they've got eczema. Otherwise, I wouldn't be considering asthma, and I wouldn't be trialing them with Ventolin. But if they are more than 12 months, I would be trialing them on Ventolin. Easy to remember the dose of Ventolin, less than 6 years, 6 puffs, more than 6 years, 12 puffs. If you look at the Asthma Foundation, they would tell you 4 and 8 puffs. So whatever you want to follow, that's fine. The things you can do in your practice is trialing them Ventolin, checking their sats, and giving them oxygen until the ambulance arrives. So these are the things you can do and you should do, because checking saturation, because I get so many children referred from GPs without being checked for saturations. It is a very risky practice, because saturations will give you an assessment of severity of their problem. So please. We
often don't have the SATS monitor for babies and kids and practices. Yeah,
if you don't have it, then you have got a valid excuse. If you have it at your practice, then check their saturations. That will give you an assessment of the severity of problem, and you can give them oxygen maybe by the time ambulance arrives. Let's move to CVS emergencies. That's pretty simple, pretty much like the adult problems. I've just touched base on AMI, so children can present with chest pain and they can have acute myocardial infarction. So don't think that children cannot have acute myocardial infarction. You can do an ECG in your practice. Most of the places have got it, and you've got aspirin at your practices. Please, please consider children who have got a previous history of congenital heart defect or a disease. They are at a very high risk of having myocardial infarction. So please consider their background history. They might have a scar. They've got a sternostomy scar. So that will give you a clue this child is likely coming with an acute cardiac emergency. He needs to be referred. Hematological emergencies, very fancy topic. You know, we do FB so often and so frequently, you know, but if they are coming with a raised white cell count more than 20,000, 25,000, you know, they need to have a look at their cell morphology. They may have leukemia. Any child with 2 cell lines down on their FBE, that is an emergency. They need to be seen by someone else. They need to be referred. So if they've got an anemia and thrombocytopenia, they've got an anemia and a undetected white cell count, they've got an anemia and no neutrophils in there, you know, this is a pediatric emergency. There is something wrong going on with this child. So please refer them. Take a safe approach. The other hematological emergency is spontaneous bleeding. So the children presenting with spontaneous bleeding, likely they have got some reason for this. It could be another bleeding disorder, but the most common is thrombocytopenia. So gum bleeding, nose bleeding, joint bleeding, you know, I think it would be safer approach to do an FB and refer them or get them reviewed by someone. Let's talk about dermatological emergencies. I hope I'm not going at a very fast pace. I've only got 20 minutes. I'm just trying to catch up. Is everything going comfortable so far? All right, good. I can see Shiraz shaking his head, so I hope everyone is okay. So let's talk about dermatological emergencies. So I think the one thing I want you guys to take home is petechial rash. So there are only 2 types of rashes in this world. One are blanching and other are non-blanching. So I mean, you know, rashes could be divided in so many different categories, but for the sake of ease, I explained to the parents that rashes are of two types. One are blanching, another one is non-blanching. If it's a non-blanching rash, I think it's a safer approach. You get them reviewed because these kids can have meningococcal infection, they can have leukemia, they can have thrombocytopenia. So this could be potentially a life-threatening condition. It's a medical emergency. They need to be reviewed. At least consider these differentials. Orthopedic emergencies. This is a very, very alarming topic. So a child is coming to you who has started limping and maybe he's got a fracture. What's your thinking process? Everyone, anyone? A 6-year-old child who has come limping to you and you found that he's got a femoral fracture. What's your thinking process?
Accidental or non-accidental?
Beautiful, Muhammad Ghadi. Beautiful. So that's what I want you guys to take home tonight from orthopedic emergencies. So any child coming with trauma history to you, any child who has got repetitive presentations to your practice, please do consider non-accidental injury. Please consider sexual assault with the female children. Every child, please expose them if they're coming with trauma and have a look at their skin. I'll give you some details here. These services are available for everyone in Victoria. It's a 24/7 service. Please ring them if you're not sure. Please get advice from them. How much more time I've got out of my 20 minutes?
Another 5 probably. Wasim?
Okay, I'll try to finish in another 2 minutes time. Genitourinary emergencies. So guys, anyone who has not passed urine for more than 12 hours, I'm talking about pediatric population. that is an emergency. They are dehydrated. So in the neonatal world, if someone has missed more than 1 feed, in the other children, if they haven't passed urine for more than 12 hours, this is an absolute emergency. They are definitely dehydrated. So if they don't have a wet nappy for more than 12 hours, please refer them. Priapism. So, you might see children presenting to you with priapism. Please do consider leukemia. Please do consider. I wanted to ask this question to you guys, but I forgot to delete it from there. Leukemia. I've already given you the tip there. So to children presenting with priapism, please consider hyperviscosity syndrome secondary to leukemia. So that is an absolute emergency. They are in the life-threatening situation, guys. Hematuria. So there are 3 main differentials. So post-streptococcal infection, stones, and tumors. So a child presenting with hematuria, it's an emergency. Please refer them. So in short, take-home messages overall from my presentation. Please ask about the feed of the child. If this baby is feeding well, is a healthy child. Please check their current weight. If they are putting on weight, likely they are thriving and they are healthy. Please check their blood sugar and consider non-accidental injuries. Here are some of my contacts. Anyone who is interested to make a referral, or if you need any advice about pediatric presentations, feel free to make a referral to me. I work at a few different places. Thank you very much for everyone giving me an opportunity and listening to me. Any quick questions? I really apologize. I would not be able to stay any longer. I'm already late, but any quick question, I'm happy to answer in next 1 or 2 minutes.
Just on the rectal bleeding, you said it's really serious in neonates. When should we be worried? I kind of missed what you said there.
So before they are term, if they are premature born, but they are discharged from hospital and presenting with blood in the stools, they can have necrotizing enterocolitis. That is the only one thing you guys need to remember. Otherwise, as I mentioned, if they are post-term, unlikely to be a medical. It could be still. I mean, I've seen children with the. Remember, blood in the stool is different from isolated PR bleeding. If an isolated PR bleeding in pediatric population, that is likely a pediatric emergency. But I mentioned blood in the stool, so that is different from an isolated bleeding. I hope it was beneficial for you guys. Wish you all the best. Have a good night and have a good weekend. Bye, everyone.
That was great.
Thank you. Thank you very much.
Jazakallah khair.
Any other questions? Anybody?